Hello, this is Dr. Boehm in a video about measuring clinical attachment levels. While general dentists usually do not measure or record attachment levels in daily practice, knowing how to measure attachment levels is useful for periodontal diagnosis, even if it simply comes down to determining if attachment loss is present. Measuring of clinical attachment levels is important in periodontal research and also is valuable for monitoring areas of gingival recession. Measurement of clinical attachment level is not difficult, and I will demonstrate this here on a typodont. First, determine the location of the cement-enamel junction, which in this case is readily visible. Then, insert the probe all the way to the floor of the sulcus. The attachment level is the distance between the cement-enamel junction and the floor of the sulcus, which is the same as the position of the cement-enamel junction against the fully inserted periodontal probe. Here, the clinical attachment level is 7 mm. For midlingual and midfacial surfaces, recession added to probe depth gives the attachment level, so 3 mm for pocket depth and 4 mm of recession gives 7 mm of attachment level. One can also say, since the clinical attachment level in pristine periodontal tissue is 0, the attachment loss equals the clinical attachment level, which is 7 mm. Let's repeat this measurement at the distal palatal line angle. First, find the cement-enamel junction and insert the probe to the sulcus. The clinical attachment level here is 8 mm. Here is another case where the cement-enamel junction is visible on the facial side. So again, find the cement-enamel junction. Fully insert the probe. And here the attachment level is 14 mm with a recession of 1 mm and a pocket depth of 13 mm. As before, the math adds up. Now, what if the cement-enamel junction is not visible? Here, the first task is to feel for the cement-enamel junction. The cement-enamel junction should feel as a linear feature that encircles the tooth, usually the point where smooth enamel ends and rougher root surface begins. Usually, there is also a step down with the probe as the probe slides off the enamel onto the more constricted root surface when inserting the probe apically. So here, the cement-enamel junction is 1 mm into the sulcus. From there, insert the probe fully into the sulcus and see how much further the probe enters the pocket. Here, it is 7 more mm from the cement-enamel junction, which is the attachment level. You can also see the probe depth here, which is 8 mm from the gingival margin to the base of the pocket. Here is a clinical view of the clinical attachment level in an area with gingival recession. Here is the cement-enamel junction. Here is the gingival margin with a distance of the cement-enamel junction to the gingival margin at 2 mm. Now the probe enters the sulcus, which is a little more than 1 mm deep, so 2 mm rounded up as probe depth. So the clinical attachment level here is 4 mm. Here is a case where we want to measure clinical attachment level at a deep interproximal pocket where the cement-enamel junction is not visible. So we feel for the cement-enamel junction first and use the side of the tooth as a landmark. The probe now is at 6 mm. We insert the probe now full into the pocket and the probe now is at 10 mm. The difference in probe position is 4 mm, which means the pocket floor is 4 mm apical to the cement-enamel junction. Therefore, the clinical attachment level is 4 mm at this site, and there has been 4 mm attachment loss at this site over the patient's lifetime. Given that periodontitis is defined by attachment loss and the remainder of the patient's presentation matches the typical appearance of biofilm-induced periodontal disease, we can say for this site that the patient likely has moderate periodontitis. I hope this presentation helped you understand the concept and how to measure clinical attachment level.